Good afternoon, my name is Catherine Tejan and this is my Sentinel event project presentation. So for my presentation, I wanted to go over a patient that I met during my clinical rotation at San Ramon Regional Medical Center. We're going to call him GS just for HIPAA reasons. So GS was admitted to the emergency department on October 24th, 2024 for urinary hesitancy and urgency. During the initial triage interview with my assigned registered nurse, who ended up becoming his nurse during his duration of his stay during that shift, we interviewed him and discovered that he had recently stopped his tamsulosin therapy and he had a previous diagnosis of BPH, or benign prostatic hyperplasia, in full. And he stopped that about 2 weeks ago and started experiencing symptoms about a week ago. So we kind of anticipated at least starting a one-time dose of the tamsulosin therapy if appropriate for the patient and continue with the prescription. So after that, we talked to the emergency room doctor once we got him roomed and comfortable, and the doctor prescribed that we put an indwelling Foley catheter in the patient since the patient was retaining over 1,000 cc's of urine. So I went in there and the nurse asked if I was comfortable, since we are LVNs, inserting a Foley with him just observing in the room, and I said yes. So I went in there and I actually wasn't able to insert it because the patient's penis was very restricted and he presented with some phimosis. He said that he had never been able to get a catheter into his penis previously when he had had urinary retention problems before. So after that, we talked to the doctor and we decided to use a pediatric indwelling Foley catheter just to get some relief off that bladder and hyperinflate the balloon so it wouldn't pull out. And even then, I think it was an 8 French Foley catheter, we weren't able to do it. So after that, we tried a straight catheter, and they're a little different than ones that I've seen in the past. It was like a short, really skinny little straw, just because it's a little bit harder and it's is able to go through a smaller hole, and even that, we weren't able to get any urine outflow from that. So we let the doctor know, and the doctor came in and talked to the patient about what methods were used prior, and the patient had said that in the urologist office they had just started the tamsulosin therapy and that had worked well. During the few hours that he was in the emergency room, we ended up determining that the patient is able to have a very scant amount of urine outflow, but not enough to clear out the kidneys no matter how hard he tried. So we ultimately ended up discharging the patient and contacting a urologist at another hospital who was on staff, who was able to use more specialized tools to help relieve the patient's bladder of extra urine as well. So for this situation, the patient ended up being stable and we were able to discharge him safely. However, for the Sentinel project, I just wanted to go over a couple of potential things that could occur in issues where a patient is retaining a lot of urine and may present with a potential AKI, or acute kidney injury. So for the kidneys are primarily responsible for fluid and electrolyte balance. So the two potential serious events that could occur that I went over in my paper were hyperkalemia as well as fluid retention. So for both of these, the recommended therapy is like diuretic therapy, stopping or decreasing any potassium sparing medications that the patient might have previously been taking as well as discussing with the patient alternative treatment measures. So for this patient, the doctor that had put him on the tamsulosin therapy had discussed with him getting a circumcision done to help treat that phimosis and hopefully help with the obstructed urinary flow. We talked to the patient for a while about it just to see if he had any religious or personal reasons, to which he denied. So we reinforced teaching with the doctor as well about possibly scheduling that procedure and how that could help him as well. And also, before we transferred him to that other hospital, we gave him a one-time dose of tamsulosin and told him to Take the tamsulosin long term, even if your symptoms start feeling better, because that means the medication is working. And once the medication, just like most meds, once they're flushed out of your body, they're not going to be effective. So those symptoms are going to come back. So let's see. So I talked about fluid retention, also hyperkalemia. So with hyperkalemia, as we learned in class, can cause cardiac dysrhythmias, which can be life-threatening. It can cause a heart attack. So when a patient comes in with issues of hyperkalemia, we want to put them on continuous cardiac monitoring to make sure that their heart is functioning and pacing okay. And if it is not, that we're taking the appropriate pharmacological and nursing measures to treat that as well. And I think that is it. Thank you.